Hello, World Clinicians. I'm Ali Nasseh, and I'm joined here today by Dr. Ian Grayson, our own faculty at Harvard School of Dental Medicine. Ian, thank you so much for joining me.
Thank you for inviting me.
Well, Ian has a presentation coming up at the AAE meeting coming up in Nashville in April.
Yeah.
And he's presenting a topic on an article that he recently published on autogenous tooth transplantation, where he discussed the case that he had done. And I figured it'd be a great opportunity for us, Ian, if you would be willing to share the case that you recently published with our viewers so we can have a little discussion about autotransplantation and autogenous tooth transplantation and so on, and go from there. So why don't you take it?
Thank you. So in the past, what we normally have done, where we have teeth that have been lost through trauma, avulsions, that kind of incident, when that normally happens, we don't merely discard the tooth. We take that tooth and we reimplant it, and in many, many cases, we get a very high degree of success with that kind of procedure. Now, what I'm proposing is that we take that exact same principle, which is based on biological principles, and we take it and we basically have an avulsion, which is under controlled circumstances in a controlled environment, and we reimplant it in a different site within the mouth where we have all the prerequisites for good biological healing. And that's essentially what we're proposing here with autogenous tooth transplantation.
Which, again, is kind of similar to what we've been doing with intentional reimplantation, or, as you said, just regular traumatic avulsions, right, or intentional avulsions. But you're taking it up to the next level, and we're talking about taking a different tooth and putting it into
a separate site.
Same person, however, right?
Right.
It's not a transplantation from one person to the other.
It must be the same person, obviously, because you've got an immune system. And if you took a foreign organ or foreign matter, put it in, you'd get a huge rejection problem, and it obviously wouldn't work. But here, we're taking the same antigen, same antibodies, reimplanting it from one site to another site to create a functional entity within the oral cavity.
So this case, you want to tell us a little bit about this case?
Sure.
That you did?
This case started about 2.5 years ago. It was in Toronto, and it involved a 17-year-old male who presented to the office with a first molar, tooth number 19, which had previously been root canaled. But when the patient presented, we noticed that the tooth was fractured. It probed, it had a single isolated pocket, and it had a classic J-shaped lesion on radiographic analysis. So the options for this particular gentleman were we can remove the tooth. Because he was very young, we could have preserved the space and at some point in time placed an implant, or thinking outside the box for our topic today, we gave him the option of potentially taking his third molar, which was not totally developed. It was approximately 2/3 root development, so it had open apices and 2/3 root development, allowing that tooth to take the place of the first molar following extraction. So we gave him that option.
Terrific. So what are some of the main indications for this particular case? Obviously, a young patient that has a non-extracted wisdom tooth that is ideally still developing, right? Would you say that?
Correct.
Anything about the anatomy of the tooth being removed and the socket and that it will leave behind versus the anatomy of the wisdom tooth and so on?
So there are a lot of indications for both the donor and the recipient site. In terms of the donor site, it must be a tooth that can be extracted without sectioning, obviously, because the less traumatic it is when we're extracting the tooth, the more viable it's going to be. And the number one item that we're looking at, the number one portion of the tooth, is preservation of the periodontal ligament. So what we have to do is we have to extract that tooth as atraumatically as possible so we can preserve as many of those periodontal ligament cells as possible. So when it's transferred to the new site, to the recipient site, those periodontal ligament cells will repopulate the surface of the root, and they'll start growing a new periodontal ligament, and it'll be a functional unit again.
Are there any studies in terms of what is the cutoff point from at what point, obviously for the dental follicle to be present, you have to have the epithelial root sheath and so on. Yeah. So at some level, certainly we're not talking about just removing the crown, right? I mean, there has to be some roots in there, right? So is there a cutoff point?
So what you're doing is you're extracting the tooth. Generally speaking, you will find the follicle surrounding the tooth, and within that follicle is Hertwig's epithelial root sheath, as you were mentioning. And those cells, as long as they're present, will allow for continued root development as long as that is transplanted with the actual tooth. That's why we try to do it as atraumatically as possible.
So usually that would translate into what age group? And of course, there's a standard deviation, variety, and so on. Is it mostly in teenagers? Certainly, I would assume for someone who's like 8 years old, if they have that issue, it's probably going to be too early for their wisdom tooth.
So ideally, what we want is we want a tooth which has approximately 1/2 to 2/3 root development. That's in an ideal sense. We want a wide open apice because we want to allow for blood vessels to revascularize that area and regenerate the area. And we want to have odontoblastic growth because we want to get continued root development. We also want to get thickening of the root as well for support.
Because, Ian, generally, in this is a particular situation in which we're not doing a root canal prior to the extraction and replacement. This is a situation in which you need to have a tooth that's young so that it can continue the regenerative process. Whereas sometimes you can do transplantation of the second molar into the first molar side.
Yes.
Because it's an adult situation, you'd have to do
a root canal. And in that particular case, you're transplanting. You can do the root canal prior to transplantation, or you can transplant the tooth, let it settle for a couple of weeks, do the root canal. My suggestion is you put calcium hydroxide in for 2, 3, 4 weeks, allow that to settle, and then complete the root canal. In that particular case, you can have success as well. But the most success you have is from immature teeth, according to the literature, where you'll have some continued root growth within the socket.
True.
So getting back to this particular case, it's a 17-year-old Caucasian male who came in for a routine dental visit. And when we did our examination, we noted a sinus tract adjacent to tooth number 19. And on x-ray, there was a classic J-shaped lesion. When we did our periodontal probing, we certainly got a single isolated pocket mid-mesial. And we decided at the final, for the final diagnosis, that this was a fractured tooth, and the salvageability was nil, had no prognosis. So the only option here was to remove that tooth. Now, we could have removed the tooth, and we could have left the area until the patient had finished his growth, maybe 1920, and then an implant could have been placed, or we could have taken the wisdom tooth and transposed it or transplanted it into the socket of the first molar. And after a thorough discussion with both the patient and his parent, we decided to go ahead with the auto transplantation. So we see here that we have all our preoperative records. You can see from the photograph there's a sinus tract on the buccal gingiva there. In the panorex and the periapical x-rays, we can see here that there's a J-shaped pattern around the mesial root. We can see from the panorex x-ray that there's a wisdom tooth, tooth number 16, which is fully encased in bone. It's about 2/3 root development, and it is an ideal candidate for transplanting into that first molar socket.
Was there a CBCT in this case too, or not?
No, there was not in this particular case. But it is recommended that with a CBCT, you can get a very, very accurate three-dimensional representation. The only thing I did in this particular case was I measured mesiodistal width between the second molar and the second premolar, and I measured the mesial distal width of the wisdom tooth, and they were both almost identical. So I knew that I wouldn't have a problem with that. And certainly I wouldn't have a problem with vertical because one tooth has complete root development, the other tooth only has partial development. So I knew it was going to fit in quite well. So the treatment basically entailed removal first of the first molar. It had to be sectioned and removed in 2 fragments, a distal and a mesial fragment. I did not extensively curette the socket because there are certain periodontal ligament cells which are present on the adjacent walls of the socket. I did, however, curette near the apex of the tooth where there was some periapical inflammation and granulation tissue. And so once that was done, We secured the area by placing a little bit of gauze, gel foam in the area, and then we turned our attention to the wisdom tooth. The wisdom tooth was removed at the same time by making an incision, and because the tooth was fairly deep, normally I would section that tooth. In this particular case, I took the tooth out at the expense of some of the intraalveolar bone there, and I removed a lot of bone from the distal into the ramus area so that I could elevate the tooth in toto as atraumatically as possible, but without sectioning it. Following that, the tooth was immersed in Hank's balanced salt solution to maintain the integrity and maintain the vitality of the periodontal ligament cells. And once everything was prepared, the gel foam was removed, the tooth was carefully, without touching the root surface, because we didn't want to damage the periodontal ligament cells, it was atraumatically inserted back into the socket. There were some minor adjustments made to make sure that the tooth was slightly below the occlusal plane so we would not have traumatic occlusion. And once that was done, the tooth was sutured into place.
I'm sorry to interrupt, but the adjustments that you're talking about, these are adjustments to the bone, to the alveolar bone,
Yes.
to the crestal bone,
Yes.
the interseptal bone,
Yes.
and the, okay.
Yes. So we put
The
it in.
vertical bone area.
It was not quite seating quite the way we wanted. I took a rongeur. I gently trimmed some of the interseptal bone there, allowed the tooth to seat. It seated slightly lower than the occlusal plane, which is exactly what we wanted. From that point in time, it was sutured into place, and it was fixated with a physiological flexible splint going from the second molar to the second premolar, which allowed for some movement but held the tooth in place.
How long were you planning to keep the physiological splint in place?
That physiological splint was kept in place for approximately 10 days. At that point in time, we had some primary stability, and the patient had instructions to maintain this area as carefully as possible, keeping it as clean as possible, because our biggest problem here would have been infection. By the way, the patient was given antibiotics for a week afterwards, chlorhexidine rinses, and they were given analgesics, but there was very little in the way of discomfort, so they didn't really take much of that, but they did take the antibiotics, and they did use the chlorhexidine mouth rinse.
Perfect.
Okay, so we can see here, after 3 weeks, the tooth is slightly below the occlusal plane. The gingiva has started to reform again. The socket where the donor site was removed is starting to heal, and the patient is totally comfortable. We took a shot at 6 weeks. The gingival margin has totally healed. It appears as though the tooth has erupted slightly, because when we look at the periapical x-ray, they all seem to be perfectly in line within the occlusal plane. We can still, when we look at the apices, we have still wide open apices. We can still see in the periapical bone is still a radiolucent lesion there, but everything looks to be healing quite nicely. Then when we take a look at this 8 months later, we note a couple of things here. We note that the tooth is totally erupted in the plane. Now it's exactly even with the other teeth, so it has erupted. We can also note that most of the periapical lesion has been remineralized, and it looks like a normal osseous pattern. But most importantly, what we can notice here is that that very large pulpal space that we had previously has started to remineralize inside, and we're getting some calcification within the actual tooth itself. That tells us that the odontoblasts have in fact survived, and it tells us that this has become quite viable. When we look 8 months later, we have probably about 1/3, 30% more root development. We have almost total calcification, which tells us that the odontoblasts have survived, have laid down new dentin, and the tooth has absolutely no mobility, and the patient claims that it feels as though it's any other tooth in his mouth and is totally comfortable.
Now, that's a very nice results, Ian, that you got for this patient, considering the fact that, you saved them from having an implant while extracting their impacted wisdom tooth,
Right.
which had to be removed anyway.
Correct.
So it's killing two birds with one stone. It's an
Exactly.
incredible service. Patients did really well. Before we talk a little bit about the literature on this, about the outcomes in these particular types of autotransplantations, I'd be curious to hear your opinions about the potential for calcification and whether that calcification is the dystrophic calcification is a potential future problem for this patient, or do we not care? Essentially, it's nature's own root canal, which you're just going to leave it as is.
Actually, you took the words out of my mouth, because when this tooth calcifies, when you get that dystrophic calcification, the laying down of tertiary dentin within the tooth, that is a very good sign. If I looked at this tooth, say a year or two down the road, and I saw that the size of the pulp chamber and the pulp within the roots had not changed at all, odds are that tooth would be necrotic, and if we wanted to save it, we would have to do a root canal. This is nature's way of providing this patient with a root canal. It means that it in fact is healthy, and because we have that extra dentin laid down, we have strength within that root, so the odds of this tooth fracturing, i.e. through the root, is very, very limited, very low.
I agree, because this was not a situation in which you had trauma that caused the calcification. This was a deliberate removal and then replacement of the tooth in a different site.
And that's a physiological response.
And a physiological dystrophic calcification. Right. And in fact, here in the molar area, it's probably less of this would be something that could be an aesthetic problem for the patient in the anterior area. But in the molar area, obviously, we don't care about slight discoloration of this molar. So this is not a problem. Oftentimes, when you see dystrophic calcification in the anterior sextant, the only reason we treat those cases in the absence of any periapical lesion is only for the aesthetic reasons for doing internal bleaching.
That brings up another very, very important point. Glad you raised that. With this procedure versus an implant, when you're doing this procedure, in an implant, you need to place an artificial crown. Here, what you have is you have a natural crown, and you can't beat the aesthetics for this. So you have built-in aesthetics within this procedure. You don't have to worry about shade. You don't have to worry about contour. You don't have to worry about emergence profile. It's all done there for you. So it's one-stop shopping for this.
That is terrific. That's awesome. So quickly, this is a procedure that is done very rarely, and even though there is adequate support for it in the literature, there's been a lot of articles that have been described in the past stating many, many years with this concept. Can you kind of quickly just talk about some of the literature in this topic, in this area, and what kind of, what should a patient expect in terms of survival or success for this particular case?
Well, like most other procedures, this procedure is very, very dependent on case selection. If you have a patient, say, who's elderly, who's got extensive periodontal disease, who's got calcification, who's got extensive caries, it's probably not a great candidate to do this. However, on a selected group of people where you have a tooth which is non-restorable and you have a very, very viable donor, in that particular case, it is a very, very successful procedure. We are talking about survival and success rates which rival that of implants. And why wouldn't somebody want to have this procedure done versus an implant if the survival rate is the same? Another selling feature, and I'm not trying to sell this, but another selling feature of this is probably the economics of it. When you look at the cost of an implant, when you look at the cost of a crown, when you add all that up, and in some cases you have to have the potential for bone augmentation, bone grafting, when you're looking at all that type of service that needs to be provided to allow that procedure to take place, this is much simpler. In this, there is generally never any bone grafting, and if you ask why, it has to do with growth factors which are emitted from that tooth which is transplanted. As soon as the tooth goes into the socket, immediately it's osteogenic. It tends to stimulate the bone in the surrounding areas to come in, to migrate, to lay down new osteoblasts, new osteocytes within the area. So grafting is never a problem there, and when all is said and done, the stability of the tooth can't be beat if it's successful. So from an aesthetic point of view, from a cost-effective point of view, it's a very, very viable treatment option in the right cases. I have to stress that.
Yeah, and I can see that, there's a lot of articles that have already been published in this area, and with follow-up periods that are fairly respectable in terms of the number of years, and you can see that some of these are really in the high 90s in terms of survival rate, which really is, in my opinion, is the essence of doing these things, is survival, because that's essentially what implants are based on, a survival rate. And So it's a viable option. The only issue I see is that for this particular situation where we don't end up having to do the root canal, it creates a very niche group of patients, right? It's like a specific group, a number of years. I would maybe like a 13, 14-year-old all the way till like a maybe a 20-year-old or so. And then once the root formation on the wisdom tooth is complete, now you're going to need to do the root canal on it as well. If you do
so the pool of patients that are eligible for this as one ages obviously gets less and less. This is a very, very viable situation for prepubescent teenagers, for young adults. But as you get older, the transplantation will certainly involve endodontic procedures as well, but that's not to say it can't be done. It can be done, and it can, in many cases, be offered as an option.
No, there's no question about it. I think this is an area that needs to be, because everything that we've learned in the past decade in terms of regeneration has now opened up a whole new path for us to understand the ideas of regenerating not just the pulp, but also the periodontal ligament around the tooth and all of the tissues that are involved here. I think the main challenge here remains the treatment planning portion of this, so that you can apply the right treatment to the right patient.
Right. That's everything. Treatment planning and patient selection is paramount in this. And following that, it's your technique. Now, obviously, you have to be comfortable removing teeth. If you're not comfortable removing teeth, but you're aware of the procedure, then allow the patient to have the procedure, refer it to somebody that has that field of expertise, where they can take teeth out, and it has to be done atraumatically, reimplant atraumatically. And if it's done, that's a great service for your patients. And your patients will certainly appreciate that, even if you yourself are not comfortable doing the procedure.
No, I agree 100%. Now, as a final thought to kind of finish this up here, is I can foresee in the future that the combination of using three-dimensional imaging as a modality for treatment planning, combined with potentially 3D printing, can allow us to do a pre kind of analysis. First of all, using the three-dimensional imaging measurements to see what kind of, arch space we have.
Actually, it's here now. So what we actually do is, using CBCTs, we 3D print a tooth which is identical to the donor tooth, and we take that model and we insert in the socket. We make our adjustments with that model, so when the tooth comes out, it immediately fits in, so it saves some time. And it's here now. Now, if you want to jump even further, we're going to go into the future quite a bit. If you want to jump into the future, I can see the era at one point in time, we can actually take cells, stem cells, grow teeth outside, so in vitro, and take those teeth with sockets we've created and reimplant them. So that's taking it one step further, but I'm not sure when that's going to happen.
Yeah, I mean, we're still at the point where we're trying to just grow basic bone on a petri dish. We're going to have ways to go before we get proper organs with shapes, and then we kind of unlock that genetic code. But that idea of having a printed thing, we had at our treatment planning course at the school, one of the residents who's now graduated, DeBose, kind of showed a case that she had done using the same type of autotransplantation with a printed tooth, and that was very nice too. So I think 3D imaging and measurement will go a long way with the 3D. Is that the printed tooth?
This is a 3D printed tooth. Actually, we have one, and we can show our audience that.
Awesome.
So this is the 3D printed tooth. This is the actual tooth.
Look at that.
This was fit into the socket, and all the adjustments were made utilizing that 3D printed tooth. And it just increases our success rate, because the less time that tooth is outside the oral environment, the
this way
success.
You may not even need the Hanks Balance Salt solution, because you pre-fit everything. You extract the tooth.
It goes.
You take your model. You prepare the socket. You're ready to go. You open up, remove the wisdom tooth, and immediately place it into socket, and that'll save you a lot of time. That's awesome.
And increases your success.
Well, Ian, this is a wonderful case. I'm looking forward to see more of these cases. And for those of you who are attending the AAE meeting coming up in the Nashville in the 2020 meeting, you're presenting on that Friday of the meeting, and you're going to be talking about a bunch of cases and talk about this stuff in more detail. So terrific, as usual. Dr. Grayson, it's always a pleasure having you here with us. Our audience love you, and and you're always very thorough in your presentations. So thank you
very much.
Absolutely.
Okay.
So we will then with Ian Grayson, and let's save some teeth.